Good afternoon, everyone, and thank you for calling into the webinar series. Today we're going to be talking about a few different topics in the nursing home industry. We're going to be talking about the long-term care phase 3, which is today's November 21st, so we have 7 days in order to be in compliance with our phase 3 mandates. We're also going to be touching on resident discharges as well as arbitration. And okay, sorry, a little difficulties there. So let's get started. I see there's a lot of you that have actually called in. Phase 3. So we're all in compliance with phase 1 and we're in compliance with phase 2. We have about 7 days to get into compliance with phase 3. Of course, except with the CMS revisions. So CMS proposed revisions to these requirements and for two specific things. They proposed revisions to the Compliance and Ethics Program and also to the Quality Assurance and Performance Improvement Program. Now, keep in mind that until these revisions are finalized, the requirements are current. So whereas CMS has indicated that they're going to put this off for a year, that has not been finalized. So unless it's finalized within the next 6 days or 7 days, if my math is correct, we have to be in compliance with these rules. So what do they tell us? What does phase 3 tell us about compliance and ethics programs? Phase 3 requires that the operating organization of each nursing home have a compliance and ethics program by November 28th of 2019. CMS has proposed to delay this implementation for a year, but again, it is not final, so we still have to be in compliance. So just a little history lesson, let's go back a little. As of 2005, under the federal laws, we had to have, the nursing homes that had $5 million or more in Medicaid dollars had to have corporate compliance programs. In 2007, the state came out, New York State, and said, we're going to change the $5 million to $500,000. So if you get $500,000 in Medicaid monies, you have to have a compliance program. Plus, if you're in Article 28, even if you make $1.72 from Medicaid, you have to have a compliance program. So this should not be something new for us. We've had to have compliance for over 10 years. The federal government tells us that there's 7 steps in a compliance program. The state government tells us that there's 8 steps in a compliance program, and you'll see from these phase 3 regulations that they add a few steps and kind of change things around. So the operating organization is the ownership. Who are the operators? And whoever it is that's operating the nursing home must have a compliance program. Okay, so this is just a little bit of the history that we already discussed. So we already in New York have to have compliance programs, and it's mandatory. And just as a little reminder, by the end of this year, as we do every year, I guess you have 5 weeks or so, we must certify through the OMIG website that we have a compliance program. Okay, so what's the definition under phase 3 regulations of compliance? It has to be a program that's reasonably designed, implemented, and enforced so that it's likely to be effective in preventing fraud, waste, abuse, and detecting criminal, civil, and administrative violations. And it has certain requirements. So what CMS did recently is they amended the requirements or proposed to amend the requirements for this particular portion of phase 3. So, and by the way, and I should have said this right in the beginning, these slides will be sent to all of you as well as a YouTube video of the presentation, I think tomorrow. Okay, so follow me on this for a second, because these are the specific requirements for compliance. And what you see in red is the language that CMS proposes to delete from these rules. Okay, so red is what they propose to delete. So the first requirement, which is to have written policies and procedures, which I'm sure most of us, if not every one of us that's listening on the phone, has these corporate compliance policies and procedures. So what they're looking to get rid of are the more specifics. So things such as there has to be an appropriate contact to which individuals report suspected violations, a method of reporting anonymously, disciplinary standards. But don't think that they're just taking that out of the compliance program. What they're doing is they're kind of moving it around. So what they're saying here is your policies and procedures, we're not going to specify exactly what things you have to have in your policies and procedures, but don't worry, because later on they'll tell you we want to make sure you have A, B, and C. Okay, the second prong, to assign specific individuals within the high-level personnel of the operating organization with the overall responsibility for compliance. So what are they proposing to take out? Again, the red is what they're proposing to delete. And what they're proposing to delete is that the individuals may be the CEO, members of the board, or directors of major division in the operating organization. Again, they're not looking to do in my view, they're not looking to micromanage who it is that we have as the compliance officer. For number 3, provide sufficient resources and authority to the individuals to reasonably assure compliance. Any of you that have ever heard me speaking before, how do we do this? We need to have a compliance budget. When the government comes in to look at our compliance program and they are asking us for the policies and procedures and everything else that we do in compliance, they're going to say, what are the resources that your particular facility puts towards compliance? And we're much better off if we have a budget. These are the resources. This is what we do. It'll be much better off when we're getting audited. But again, they didn't change. There's no red here, so they didn't change this. This continues from the original rules. Number 4, use due care not to delegate substantial discretionary authority to individuals who are known to have a propensity to engage in criminal, civil, or administrative issues. That has not changed. Number 5, take steps to effectively communicate the standards, policies, and procedures by having mandatory training programs, disseminating information. Again, that has not changed by way of the compliance requirements. Number 6, reasonable steps to achieve compliance with program standards. Here, they are looking to take some of the previous requirements out, and by they, I mean CMS. And one of the things that they have looked to delete from here is having a process for ensuring the integrity of any reported data. So I'm actually happy that that's coming out, because that's a very difficult task to do, especially when we have the obligation to review all and investigate all compliance concerns that are sent to us or that we hear of in whatever form. Number 7, there's no changes in number 7, which is consistent enforcement of the operating organization's standard policies and procedures. So what does that mean? That means that there has to be discipline. If we have an individual that we believe has done something or that we have proven has done something, we must have discipline. There must be some kind of discipline for that individual. Number 8, no changes to number 8. After a violation is detected, we have to take all reasonable steps. Number 1, to fix the violation, and then number 2, to make sure that it doesn't happen again. So what does that mean? If we find some kind of billing error, we need to fix the billing error. We need to pay back monies if that's appropriate, and we need to train people or whoever it is that made the error so that we are assured as best as we can be that that error does not occur again in the future. Okay, number 9. There are changes to number 9. Now remember I said before, if you look at the federal sentencing guidelines, there's 7 steps to a compliance program. If you look at the New York rules, there's 8 steps to a compliance program. And this now, the phase 3 long-term care, they have 10 steps to the compliance program. So number 9, the operating organization for each facility must review the compliance and ethics program. It used to say annually. They're proposing to change it to periodically, which is much better. They need to revise, identify, any changes that are necessary. And they have proposed to delete that reflect changes in applicable laws and regulations, and also to delete to improve the performance in deterring, reducing, and detecting violations in promoting quality of care. So as I view it, they're looking to not be as specific or micromanage as much as the original ones said. But they did add a 10th. So as I said before, red means that CMS has proposed to delete the information. Black now means that they are proposing to add to the regulation. So number 10 is the facility has an alternate method of reporting suspected violations anonymously. If you go back a few slides, you'll see that they had taken that out of the requirements, and then they're adding it as a separate, independent, individual requirement. Okay, so CMS has also noted in the commentary that long-term care facilities should be integrating issues from their quality assurance program into the compliance and ethics program. And for those entities that are in New York, this really isn't something that's really very new, because the New York regs indicate that quality of care is a component of the compliance program, and we should be integrating those together. Okay. So again, red means delete, black means add. So this is an additional requirement is that that's applicable to the operators, to the operating organization of a facility, to the operators. And this one is for 5 or more facilities. Now in New York, each nursing home is a separate corporation and has to have its own compliance program. So we've actually called CMS on this because we're not really sure what they mean by operating 5 or more facilities. The best we've gotten is that that's for other states that are allowed to have such a structure. But what they've proposed to get rid of is to say that they have to have a mandatory annual training program on the operating organization. That does not mean the individual nursing home, on the operating organization's compliance and ethics program. So I think we're all in New York, so we're going to move on. Okay. They added for the operating organization, they need to have a compliance officer with responsibilities to report directly to the governing body. That is not new in New York, and even though that's deleted, that's something that we all do anyway. And the addition is to develop a compliance and ethics program that is appropriate for the complexity of the organization and its facilities. So if you're outside of New York and there's an operating organization that has 5 nursing homes, that compliance program is going to be run and it's going to be funded differently than an organization that has 100 nursing homes. Okay, so the state will be surveying on corporate compliance programs. There has been no, as recently as of last week, there's been no training to the state, there's been no guidance to the state as to how to survey on the compliance program. My strong belief is that the state surveyors at some point in the future may be coming in, asking for your policies and procedures and looking at your plan, but I am not sure that they will actually be able to do, dive into our compliance program. I think it's more likely that they'll look to make sure that we have one, and then move on. And then in New York, OMIG, as you know, comes in and reviews compliance programs for different entities. So I suspect that that's how it will continue, but I don't know for sure. Okay, so other phase 3 requirements. Okay, so these pertain to administration, QI, and performance improvement. So under phase 3, and again, this is proposed to be delayed for a year. It was proposed to be delayed for a year in July of this year. However, nothing final has come out, so we can't go along as if it was actually delayed. So the governing body has to have overall responsibility for the quality assurance program. It can be executive leadership or an organized group, but they must be responsible and accountable for ensuring numerous things. So how do I read this? You cannot have a board or an owner whom will later claim, I'm not really involved in the operations, so I'm not really up to speed on the quality or issues that may be happening in the nursing home. Because under phase 3, that's not going to be acceptable. So what are they saying? That we have, that the ownership or the board members have responsibility for, okay? For making sure that there's an ongoing quality assurance program, that it's defined, implemented, maintained, and addresses specific priorities. The priorities should be whatever the priorities are, whatever the issues are that we have in our particular nursing home. So there must be governing board responsibility. What else are they responsible for? They're responsible to make sure that the quality assurance program is sustained during transition. So getting a new director of nursing, getting a new administrator, that is not an excuse for not maintaining and continuing the quality assurance program, nor will the government accept it as an excuse. The quality assurance program should be adequately resourced. There's enough money that's being put into it. There should be enough staff time into it, equipment, technical training, whatever is needed in order to make sure that we are providing the residents the highest practicable quality of care. Also responsible for identifying and prioritizing problems that we may have in our nursing home, for corrective actions, ferreting out if there's any gaps in the system, what are we going to do to fix it, corrective actions, and clear expectations regarding safety, quality, rights, choice, and respect for the residents. Okay. Our infection preventionist, that individual, which we should already have, must be part of the Quality Assurance Committee. So while CMS proposed to delay some of their revisions in the July 19th pronouncement, they do not look to delay this. So every one of us should have an infection preventionist, and that person should be on the Quality Assurance Committee. Okay. Other things that we need to have for next, the 27th, which I guess is next Friday, 28th, which is next Saturday. Phase 3 requirements must have a coordination of resident rights to freedom from abuse, neglect, exploitation. That all needs to be part of the QAPI program. I think most of us already have that. Comprehensive person-centered care to include trauma-informed care and call systems on bedside. I don't know any nursing home that doesn't already have that. Okay, training. Facilities must develop, implement, and maintain an effective training program for new and existing staff, individuals providing services under a contractual agreement, volunteers. I'm not sure that we all have training programs for our volunteers, so if we don't, we need to develop them. And based on the facility assessment, the facility should be determining how much training is necessary and for whom. And we must be training. There was a lot of required topics in the phase 1 regulations, a lot of required training topics. So if we're not sure if we're actually doing those, we should be going back and double checking to see that we're covering all those. There's additional topics for phase 3, which I'll go through quickly. Effective communications, residents' rights, which we already do in New York, QAPI elements and goals, which for the most part we do in New York as well, infection control, compliance and ethics. But we need to add at this point in-service training for CNAs to address areas of weakness in their performance, and also to address special needs of the residents. Finally, behavioral health. We also should be doing the behavioral health training. These are all required under phase 3. Okay, so moving right along, and actually before we move right along, I should have said in the beginning, if you have any questions as I'm going through this, I think you could type them in and I could see them and respond to them. So you don't have to wait till the end is the moral of my story to ask questions. Okay, let's talk arbitration. So a lot of nursing homes in the past wanted to have residents sign arbitration agreements. In 2016, there was a prohibition from nursing homes entering into arbitration agreements with the residents. This prohibition was challenged. The federal courts ruled that the nursing homes would likely be barred from doing these arbitration agreements, and they granted a preliminary injunction. So from 2016 till today, we couldn't really do these arbitration agreements with our residents. So in July of this year, the Department of Health and Human Services, while they didn't appeal, they put out a proposed rule, which is basically on how a nursing home actually can enter into arbitration agreements with their residents. Okay, so this is how we can do it, okay? If we want to have our residents sign arbitration agreements, the facility must comply with all of these things. Now, keep in mind that in the past, what some nursing homes did was they kind of threw the arbitration clause or the arbitration agreement into the admissions agreement and had the resident go through, you know, a 20-page package and then sign at the end. My recommendation would be keep this separate and make sure that you dot every I and cross every T. And let's talk about what those are, okay? So you cannot require the resident to sign an arbitration agreement as a condition of admission or as a condition to treatment. And the facility must explicitly inform the resident or the designated representative of their right not to sign the arbitration agreement, and that it will not be, I guess, held against them, for lack of a better word, for admission or in any type of care that they receive in the facility. The agreement must explicitly state that neither the resident nor his or her representative is required to sign an agreement. It must explicitly state. So it's not just what we're explaining to the resident or the family member. It actually has to be in the agreement. It must say, you do not have to sign this. And it also has to give the resident or family member the ability to rescind the agreement within 30 days of signing it. It cannot have any language in it that limits the resident from speaking to any kind of federal, state, local official, including federal and state surveyors that may come in and to talk to the resident. So we cannot restrict, there could be no confidentiality provisions in this. We cannot restrict the resident from talking to anybody or the family member from talking to anybody regarding this arbitration agreement. Okay, so what else do we have to do to have arbitration? We have to make sure that the agreement is explained to the resident and his or her representative in a form that is understandable and in a language that's understandable. So if Spanish or whatever the language is the first language of the resident where they're most comfortable and we're going to enter into one of these agreements, it has to be in Spanish and explained in Spanish and or any other language. The resident or the designated representative has to acknowledge that they understand the agreement. The agreement has to provide for a neutral arbitrator that's acceptable by both parties. So the nursing home can't, pick Lourdes Martinez as the arbitrator. It has to be somebody who's mutually agreeable. And the venue has to have a selection of venue in the agreement that is mutually agreeable to both parties. Okay. If there is a dispute and it's resolved through arbitration, all of the documentation that has gone into the dispute, including the decision, has to be kept for a period of at least 5 years. And if CMS or the state comes in and wants to inspect the documents, we must let them see these documents. Okay, moving right along. The new New York State resident discharge requirements. Okay, so effective about a month ago, the Department of Health updated the nursing home resident rights regulations to include a new right or a new section on the right to information on home and community-based services. So the goal of this was to make sure that the residents are afforded a right to exercise their rights or afforded the opportunity to live in a more integrated setting out in the community outside of the nursing home. So under the ADA, facilities have to make reasonable accommodations to assist residents in discharges to the community. We know that. Under the Olmstead case, which is back from 1999, individuals with disabilities had to be provided with community-based organizations provided services, through community-based organizations when the services were appropriate, affected persons did not oppose community-based treatments, and community-based services can be reasonably accommodated. So on October 11th, the Department of Health put out a Dear Administrator letter, and they stated that nursing homes are reminded of the obligation to uphold the Olmstead case, which we just discussed, by ensuring that the residents who express a desire to return to the community are provided with the opportunity and assistance to do so. So how are we going to effectuate that? Okay, so upon admission, we have to advise the residents of their right to live in a more integrated and least restrictive setting. So upon admission right away, we have to let them know. We also need to provide all residents with information on community and home-based services, as well as community transition programs. Whenever the resident requests information about returning to the community, or whenever the resident requests to talk to somebody about returning to the community, during any state or federally mandated assessments, all the assessments that we do for the residents, the facility must refer the resident to a local contact agency or a community-based provider of the resident or designated representative or designated representative's choosing. So a local contact agency is an agency that's designated by the Department of Health to accept referrals of nursing home residents that wish to receive information about services in the community. So we have to assist the resident in getting basically out of the nursing home and getting services in the community that would allow them to live there. Okay. If it's feasible, okay, and the nursing home resident has expressed an interest in returning to the community, the nursing home should be making a referral to the New York Association for Independent Living Transition Center. A transition specialist will then meet with the resident at the nursing home and provide them objective information and kind of give them their options. So we would need to reach out to the New York Association for Independent Living, and then they would send their transition specialist. Okay. So there's been a few questions on the MDS and Section Q of the MDS. I think there might have been a little bit of confusion, which we're going to talk about in a second, because I'm just going to go right through these slides. I put them in here so that you don't have to look for these referral forms or for the contact agencies, but I'm not going to spend any time on them. So here are the referral forms. I just wanted you to see what they look like and where you could find them. Also, the list of contact agencies, I know it's kind of hard to see on the slides, but I wanted you to have it as a resource so you could find them. Okay, so the other requirements that with respect to this new resident discharge right. Each facility has to post contact information regarding the local contact agency, and the contact information has to be posted at wheelchair level so that residents in wheelchairs can see, the contact information. You also have to have staff that's, one, knowledgeable and available to discuss the options for discharge planning with consideration, of course, to a safe discharge plan and the resident's medical, physical, and psychosocial needs. And we also need to ensure that our discharge activities align with the established transfer and discharge rights under the New York regulations. Okay, additional discharge requirements. State regulations require that the facility, so all of our nursing homes, we must provide sufficient preparation and orientation to residents to ensure a safe and orderly discharge. That's not really anything new. Develop a discharge plan which addresses the medical needs of the resident and how the needs will be met, particularly in the community. Provide a written discharge summary to the resident and allow the resident and their legal representative or healthcare agent the opportunity to participate in deciding where the resident will go afterwards. Okay, just really quick before I get off the slide. The discharge plan must contain, or the discharge summary must contain certain items. It has to have in it, when you give them the discharge notice, it has to have a summary of the resident's stay at the facility, the information regarding discharge and release of information to either authorized individuals or agencies, and a post-discharge plan of care that needs to be developed with the resident and or the designated resident's healthcare agent. Okay, now we'll talk about the MDS confusion, right? So the confusion is with Section Q of the MDS. So the purpose of Section Q is to make sure that every individual has the opportunity to learn about the home and community-based services, and also to have the opportunity to receive the care they need, the long-term care that they need in the least restrictive setting possible. So according to the Office of Civil Rights, there are 3 questions, Q400, Q500, and Q600, that have been quote-unquote misunderstood by many facilities. So here's our attempt so that we all understand it. Okay, 0400. Oh, sorry, I'm forgetting to move the slides. Okay. So 0400. What OCR has told us is that many facilities think they do not have to ask this question if the resident has a discharge plan. That is not correct, okay? A discharge plan and an active discharge plan means that it is being currently implemented. So an active discharge plan is already occurring for the resident to return to the community. So the answer to that, we must answer this question even if the resident has a discharge plan. How do we answer the question? The answer to the question is yes, only for certain reasons, okay? So going back, the question is, let's just go back on the slide, is active discharge planning already occurring for the resident to return to the community? When can we answer that question in the affirmative? Let's go to the next slide. The answer is yes to that question if the resident is currently being assessed for transition by the local contact agency that we had just discussed. The resident has a transition plan in place, which has all the required elements that needs to be in the resident's discharge plan. The resident has an expected discharge date of 3 months or less, and the resident has a discharge plan with all of the required elements. So this is when we can answer that question in the affirmative. Okay. So this is OCR's recommendation. To answer MDS question Q400, no, for all residents of the facility, unless a referral to the local contact agency has occurred and the local contact agency has met with the resident. So that "and" to me says it can't just be a phone call, I contacted them. There has to be a meeting with the resident in order for us to answer that question, no. Okay. If the answer to 400 is no, then we have to proceed to 0500. Okay. So, return to the community. This is the question. Do you want to talk to someone about the possibility of leaving this facility and returning to live and receive services in the community? Okay. According to OCR, most facilities never ask the question because the resident has a discharge plan in place. And again, going back a few slides before, unless the resident has an active discharge plan in place, the resident must be asked the question. Again, let's go back to what is an active discharge plan. Means a plan that is being currently implemented. I am in the process of discharging this particular resident. Okay. I'll stop moving around. Okay. So, if the response is yes to the question, you must refer the resident to the local contact agency. Okay. The purpose of this is to provide the opportunity to the resident to get information and discuss and see what the possibilities are for them to get out of the nursing home and be out in the community. Okay, so this is an important part that I didn't mention. So before I go to the next slide, this question has to be answered based on the resident's answer, not on the facility's belief that the resident will not be able, because of clinical issues or their medical condition, to leave the facility. The question must be answered based on what the resident wants and the resident answers, and not what we may view to be realistic, but not the resident's wishes. Okay, 0600. Has a referral been made to the local contact agencies? Okay. Facilities have to recognize with this issue, and really with all other decision issues for providers, that a resident has the freedom of choice. We have the freedom of choice for all of our medical treatments. And they cannot be pressured into remaining in the facility. So once a resident expresses the interest to learn about living outside of the facility, okay, could be by answering yes to the question before, to Q0500, or telling the direct staff, then there must be a referral to the local contact agency. This referral should be documented in the resident's discharge plan, and 10 business days has been viewed as a reasonable amount of time for this referral. So if I tell you today, I guess it's the 21st, there is no 31st, but by December 1st, a referral should be made. Okay. OCR recommendations. I am the messenger. So, facilities should not deny a resident a referral to a local contact agency for inappropriate reasons. What are inappropriate reasons? Okay. The facility inserting its judgment and overriding the resident's expressed interest based on factors that the facility believes, and the facility may be right, but it doesn't really matter, that the disability is too severe to transition, or that discharge is not possible because the resident doesn't have any home or support in the community. Again, the facility may be right, but the referral needs to be made. Or the family or caregiver does not want the resident to move. That is also not a reason if the resident says, I would like to go. Okay, so the facility should ensure, and these are general recommendations, okay, that they have a working relationship with the local contact agency. So we should have some representative in the facility, whether it be social work or whoever the appropriate person is. There should be some representative in the facility that should be a liaison to the local contact agency and kind of develop a relationship with that individual. We need to incorporate the LCA's transition plan for the resident into our discharge plan at the facility and into the active care plan. And we should also have, according to OCR, and I think it's a good recommendation, policies and procedures that reflect the MDS Section Q information, and we should update them as appropriate. And it's not just having the policies and procedures and updating them as appropriate, but the facility personnel should be trained on them so that it's not a surprise to anyone what should or should not be happening by way of this particular resident right. Okay. I guess I covered this in the last slide, but facilities should ensure that the staff are trained on Section Q. So I kind of went through that during the last slide. So they should know who the local contact agency is, what the resident rights is. We have to train on resident rights, and this is something that we should train separately to let them know because this is kind of new. What the role is of the local contact agency, what the geographic location is, when and how to contact them, how to work collaboratively with them, and what services are actually provided by New York, what home and community-based services are actually provided in New York State. We're in the home stretch, everyone. Just stick with me for a few minutes. OCR also suggests that facilities invite the local contact agencies to provide seminars and presentations for the staff as well as for the residents, so that on a regular basis, they suggest every 6 months or so that they can go over the services that are provided, any changes that may have been made, what the community-based settings in which the residents can choose to receive services are, whether it's an apartment, independent living, or whatever, and the residents' opportunity to seek a referral to such agency. So with that, does anybody have any questions? I think you just type them in, I see them on the screen, and I answer them. So I'll give you a few minutes to see if anybody has any questions. So far, no questions. Okay. Well, if nobody has any questions, again, I thank you for joining us for our webinar series, and I wish you all a very happy Thanksgiving.